Okay, so what are the complications of corneal collagen cross-linking? We can divide these complications of C3R into basically three groups. These are inflammatory in nature, which could uh, be pain, corneal edema, and sterile infiltrates. And because the delayed healing process, there could be delayed epithelialization, or which can also lead to a corneal haze. And the third and very important one is the risk of infective keratitis and reactivation of herpetic keratitis. And same complication can be again categorized into early and late group, depending on whether they are presenting early or late. So we will take most important ones one by one. And post-operative pain is the very common complaint, which is worse on the day of surgery and gradually improves by on day 5. And it's more in younger patients, as the bar diagram shows that pain reduces considerably over a period of 4 to 5 days. And it is because of exposure of corneal nerve after epithelial debridement and inflammatory mediator which is released after the procedure, as well as photochemical damage because of the ultraviolet light. And how we can prevent is we can give topical analgesia 30 minutes before the procedure in the form of diclofenac eye drops topically. And also intraoperatively, one can use riboflavin dye, which is at 4-degree cooled riboflavin dye, which also is a little soothing for the patient also, and shown to be having a less pain post-operatively. And how to manage this post-operative pain is we do apply a bandage contact lens so that the surface is covered, and we do prescribe non-steroidal anti-inflammatory. And if there is too much of pain, one can give oral gabapentin or ketorolac eye drops. Then coming to the corneal haze, it could be early or late. And early haze is most common. It doesn't affect the vision much, and it's seen in almost all cases and usually clears in 6 to 12 months. But the late haze, which is less common, but it is clinically significant, it is slow, and usually incomplete clearing happens, usually persists for a long time. And the risk factor for corneal haze are if patient has advanced keratoconus of grade 3 to 4, as earlier said, poor initial uncorrected distance visual acuity or corrected distance visual acuity, and if there are preoperative reticular microstria on confocal microscopy, these are the patients who are more prone to develop corneal haze. And the mechanism I have shown in this flow diagram on the right hand side, that as we cross-link the collagen fibers, their diameter increases and the space between the fibril increases. This increase to the increased backscattering as well as reflectance of light, which is clinically seen as reduced corneal transparencies, and we see it as a haze on the slit lamp examination. And depending on the severity of this haze and how much clarity of iris you can see, we can divide it into 4 different grades from mild to very severe. And earlier corneal has haze, as we said, it happens in almost all cases, and it usually declines by 6 to 12 months of time. And clinically, it appears as very fine mid-stromal to anterior stromal corneal opacity anterior to the demarcation line. And the management of this is nothing special is required to do this. The routine treatment, which we give in the form of topical steroid, post-operatively usually clears this off. And we should advise patient to use goggles, ultraviolet protective goggles in the sunlight. But the persistent haze is which is happens late is more, uh, it affects the visual acuity more as compared to the initial transient haze, and the incidence is around 8.6%, and it hampers the vision to a large extent. And if it doesn't disappear, in very severe cases, we may require corneal transplant in these cases. And the risk factor again for this corneal haze is we have already highlighted the advanced keratoconus, preoperative stromal microstriae, as well as preoperative activated keratocyte, like if there is a uncontrolled VKC and other thing. And the stromal scar incidence is to the tune of 2.9%, and it may not be related to a cross-linking. It may be just related to the keratoconus process and corneal remodeling in the cases of keratoconus. And this is one case from, again, Dr. Chintan's clinic, showing a corneal haze which developed after the C3R. Patient had a 636 vision on post-op day 3, and haze gradually decreased, though here we are seeing it in a slit view, so it appears more than the left one, but it actually decreased, and patient's vision improved to 6.9 up to the follow-up of 3 years. Then the next complication, or we can see, is delayed epithelialization. This is the case from my clinic. As you can see, we have a heaped up margin of the epithelium. Once the epithelium doesn't heal for more than 10 days, we label it as a delayed epithelial healing, and the risk factors are already enumerated here: the old age, very steep K readings, active preoperative inflammation, uncontrolled VKC, ocular surface disorder, and especially patient of atopic dermatitis, or if there is a limbal stem cell deficiency already there. Another very important complication is we can have a sterile infiltrate. Again, usually the onset is around on an average after 3 days post-op, and they usually appear as gray-white circumlimbal lesion. I'll just take another 1 minute. Uh, you can have present it. The symptoms are pain, redness, and photophobia, and they usually appear at the margin of the epithelial debridement. And the mechanism again is usually sometimes said to be because of immune reaction to staphylococcal antigen, or hypersensitivity reaction to the riboflavin, or phototoxic effect on the corneal stroma. And again, the risk factors are again epithelium we are again damaging, and chronic inflammation like blepharitis and VKC, and prolonged use of non-steroidal anti-inflammatory. This is another patient presenting with peripheral infiltrate, and this study has highlighted the various risk factors for sterile corneal infiltrates, and the most important risk factor is VKC, uncontrolled blepharitis, and as we have already highlighted, the use of non-steroidal anti-inflammatory disease. And the corneal edema, this is one of the most important and vision-threatening complication of the C3R, and usually starts within 24 hours and may increase up to 2 to 3 weeks and may not resolve. And the risk factor involved are thin cornea, less than 400 micron, inadvertent excessive energy delivery, or the improper focusing of the beam of the ultraviolet on the cornea, or if there is a intraoperative corneal thinning because of dehydration. That's why hydration is very important throughout the procedure. And in accurate pachymetry measurement, we may be overestimating the corneal thickness, and poor focusing, and if there is a pre-existing fuchs endothelial dystrophy. And various preventive measures we can take is to ensure the corneal thickness, uh, remove the lid speculum during riboflavin installation, timely, uh, repeated, I mean, time and again, we should check the equipment calibration that proper energy is being delivered. It is not delivering high energy, and think frequent intraoperative check of corneal thickness during the procedure, and administration of hypertonic solution if the thickness drops less than 350 micron. And this is one of the most dreaded complications, though it's rare. And these are the risk factors for the infective keratitis, immunocompromised patient. They are not following the treatment properly, topical use of steroid, as well as the use of banded contact lens and other things. And the reactivation of herpes keratitis, again, these are three cases of, recurrence of keratitis. All types of keratitis can reoccur, though epithelial keratitis is more common after CTR than the stromal reactivation stromal or endothelial herpes simplex keratitis. This is one case which showed recurrence of the disease, which are proper treated with the typical standard treatment of anti-viral treatment. There's another dendritic epithelial keratitis case. And this case of 21-year female, she had herpetic endothelitis after the 7 weeks after the after the C3R. This thing you can see fine uh, KPs and fine corneal in this case. And just last slide, and this is one case of disciform keratitis which happened following the C3R, again from Dr. Chintan's clinic, and then there could be a visual complications where there's a decrease in visual acuity by 2 lines. Again, the risk factors are older age group and best corrected vision more than 20/25 preoperatively, and there could be treatment failure of C3R, especially in cases older people where the Kmax is more than 58 diopters, and especially where the cones are paracentral. And the rare complications are corneal melt or corneal perforation, excessive corneal flattening, or limbal stem cell deficiency. And this is one case, this is a rare complication where there is a extreme stromal thinning following C3R, and there's a rare complication of one case reported in literature of development of neoplasia after deep anterior lamellar keratoplasts in C3R treated cornea. So thank you very much. Sorry for the little overshoot.